Okay, and we want to talk about painful bladder syndrome and interstitial cystitis and updates. I think as a gynecologist also, you have some problems in these kind of cases. This computer doesn't work in front of me. Okay, I will talk from here. Painful bladder syndrome and interstitial cystitis is a clinical diagnosis. It is very, very mysterious disease that patients, they are suffering because of unknown etiology. Because we don't know what is the etiology, so if it is unknown for etiology, how we can treat the disease? Always we are treating the disease based the etiology, but we don't know what is exactly the etiology of this kind of problem. Bladder pain syndrome or interstitial cystitis is a clinical diagnosis based chronic symptoms that they have pain in bladder at the urination time, urination time, and pain in the pelvic with urinary urgency, urinary urgent continency, frequency, and also some pain in the pelvic pain or in the perineum, or maybe as a gynecologist, the patients, they come to you with dyspareunia. Interstitial cystitis is the same meaning and is completely similar. Painful bladder syndrome, and because of these pains, suprapubic pain, perineal pain, urinary problems, especially when they have full bladder, they feel urgency and they feel very bad pain in the suprapubic area in the bladder. We have many definitions of bladder pain syndrome. The main one is from ICS, that the definition is with day and night frequency, without UTI, not with UTI, and also we have some cystoscopic diagnosis that we should do cystoscopy for this kind of patients. It is very common in ladies, and I think because you are mainly working in ladies, of course, I'm sure you have some mysterious cases that they have bladder pain syndrome. So patients with chronic pelvic pain, pressure or discomfort with at least 1 or 2 urinary symptoms like urgency or frequency, we should consider that they have interstitial cystitis or bladder pain syndrome. We should do urine test and urine culture. We should rule out the UTI. If our patient has UTI, so IC and bladder pain syndrome is ruled out, we should do uroflowmetry and also urodynamic for rule outing overactive bladder. I will talk that overactive bladder sometimes is very similar to interstitial cystitis. We should rule out the post-void residual urine. If one patient has residual urine because of anatomy defect or another problems, maybe it's mimic to interstitial cystitis, and also we should do cystoscopy and biopsy. But recently, because I want to talk about updates in IC and bladder pain syndrome, recently in new literature, they are emphasizing that the IC or interstitial cystitis or bladder pain syndrome is not only one disease. A lady that comes to your clinic and suffering from interstitial cystitis, and you want to put the diagnosis of bladder pain syndrome or interstitial cystitis, you should check this lady holistic. You should check all another disease that they are suffering. So we should remember that IC is not only a single disease. What is the epidemiology? 1.2 per 100,000 in Japan, and also American women, 20,000 per 100,000, because in females is common. Patients with IC also, because of the social biology problems, every day in modern cities and modern life, the epidemiology going to be higher, because it's very important that modern life and these days with stresses, with environment problems and pollutions and many blah blah things, they affect to the making higher rate of IC and bladder pain syndrome. Also, patients with chronic pelvic pain and urinary problems that I'm sure in Turkey you have a great physiotherapies in Turkey, and many patients you are referring to physiotherapies, they should consider that maybe these kind of patients, they have interstitial cystitis. Role of estrogen is very important, and we should remember that millions of patients, they are suffering from IC and bladder pain syndrome in the world without diagnosis and without treatment. So if we have a patient coming to our clinic with frequency, hypersensitivity and pain and discomfort at the urination, what is our manage? First of all, the history is very important. Then physical examination, we will check urine test, and we should rule out the UTI. And so our workup should be urine test, urine culture, cytology for rule outing tumors, voiding diary for checking the frequency, symptom scores, that how much the symptoms are serious, and residual urine. And if we will reach to IC and bladder pain syndrome, we should do cystoscopy. And if we see ulcer, I will talk in further slides that we should do ulceration. But even look at the end. At the end, you can see that if we cannot be successful for treating IC patients, even we should go to cystectomy. You cannot believe, I had a patient, male patient in Kuwait, that he wanted to do suicide because he couldn't continue the life with always pain and discomfort in bladder and suprapubic. So it is unbelievable how much they are suffering from this disease, and we cannot help because we don't know exactly the etiology. Overactive bladder. All of us, we know overactive bladder. And the patients, they are going frequently to bathroom. The capacity of bladder is smaller. It's very similar and mimic with IC and bladder pain syndrome. If the patient had urgency, urgent continency, and frequency in nocturia and bladder pain, we can consider both of them, not only one. Overactive bladder, only some patients, a few patients, they have bladder pain. If the patient had more bladder pain and discomfort, we should consider about IC or bladder pain syndrome. But if the patient has frequency, urgency, nocturia, so if it is more going to be overactive bladder problem. How we can exclude and rule out the IC diagnosis is very important for gynecologist group. If the bladder capacity is more than 350 in awake cystometry or cystoscopy, so this patient doesn't have IC. So you can do easily in your clinic. You can fill the bladder 350 or 300 with normal saline if the patient is okay and she doesn't have too much pain. So you did rule out for IC, because IC patients, they cannot tolerate the filling bladder more than sometimes 150 or 200. Duration of symptoms. If patients and symptom of patients is less than 9 months, so we cannot think about IC. IC is a chronic disease with long time and duration. Absence of nocturia maybe we have one lady, one patient that she's going frequently at morning, but we are asking, do you go to bathroom at night? But she said, no, when I'm sleeping I can sleep all the night, I don't go to bathroom. So this is not IC, because IC patients, bladder pain syndrome, they go more than 10 times at night, they cannot sleep. Symptoms relieve with antibiotic. We have, all of us, we have patients that we are giving 2 courses of antibiotic and they feel okay. Even we don't have sometimes culture, positive culture, but because of inflammation, they are okay with antibiotic. But IC patients and bladder pain syndrome, they don't reply to antibiotic. Frequency less than 8 times per day. If one patient has 4 times, 5 times frequency, it's not frequency and they don't have IC. Of course, we should consider about TB, stone, bladder stones, cancer, diverticulum, and vaginitis and herpes HPV that you know better than me. And also, if the age of patient is younger than 18, we cannot think about IC. So what is etiology? It is a little bit too many things. Sorry, but I want to show you that how many literature, how many research, they are talking about etiology of IC and the reason of disease. We don't know, but many etiology, many theory they are talking about. The etiology is not only one, it's multifactorial. It's very prevalent disease, but untreated because of poorly understood pathophysiology. The first one, this is all updates from 2018 I prepared for you. The first one and the most powerful theory for bladder pain syndrome and interstitial cystitis is disruption of the bladder gag layer. The second one is upregulated immune inflammatory responses. That's why the patient that's suffering from IC and bladder pain syndrome, they have also another immune problems. Third one is neural upregulation. The patients, that they are sensitive, they have anxiety. The ladies that they are emotional, they have anxiety, they are not flexible in their life. Also, they are suffering from IC and bladder pain syndrome. The fourth one is pelvic floor dysfunction. This is very new about etiology of interstitial cystitis. Also, leaky epithelium, mast cell activation, neurogenic inflammation, infection, long-term infection, immune dysregulation, and urothelial defect and genetic is very important. So now we know that roles of pelvic floor muscles, bowel, the patients that they are suffering from bowel disease like IBS, and sexual disorders, hyperactive sexual disorders, psychosocial disorders, stress, and the bad lifestyle, and obsessive compulsive disease. I don't know, is it common in Turkey or not? Is it common, obsessive? We have many obsessive in our country because they want to be clean for praying. They are washing a lot. They are going to toilet many times for keeping themselves clean for go to praying. So we have many OCD patients. Another common disease that is we can see at the same time with bladder pain syndrome is IBS, fibromyalgia, chronic fatigue syndrome, chronic pain disorder. Based on IDDK, classification of IC, we have 2 types of interstitial cystitis or bladder pain syndrome. The first one is ulcerative. They have ulcer in cystoscopy, and the second one is non-ulcerative. Ulcerative is 10% and severe form that we can see on a lesion in cystoscopy. Do you do cystoscopy as gynecologists in Turkey or not? Okay. So flexible cystoscopy is very useful. You can have it in your office or clinic, and you can rule out the kind, and you can diagnose the kind of IC and bladder pain syndrome. If the patient has glomerulation on cystoscopy and after distension, we will fill the bladder at the cystoscopy time and until 100 centimeter for 2 minutes, and then we empty the bladder, then we will see glomerulation. Like this. You can see, this is the glomerulation. The between, inside some vessels in the middle, and you can, because the bladder, we don't have this kind of glomerulation or vessels. We can see pink and white. And this one is another glomerulation that is very severe. The name of the red points are glomerulation. And this one we have only one. So this case is not similar to IC, but another one is IC. So if you do cystoscopy for IC patients, you should have expectation having that one, the another in the right side. Bladder is like this, it's like bleeding inside. And the round shapes blood vessel is glomerulation. And all of them is glomerulation. They have IC. But this is not severe form. Right up is very severe. It's like bloody bladder. And about the ulcer, if we will see ulcer, that some glomerulation going to be collected together, we see, we name Hunner ulcer. Hunner was somebody names that he discovered this ulcer. So if we will see Hunner lesion, this is very severe form, and we should do fulguration. We are going with cautery, you know. We have some cautery, we are doing TURP or TURB for coagulation of tumor, a small tumor. So we do fulguration for this kind of lesion. This is Hunner ulcer. We are doing fulguration, or another treatment is resection of ulcer, like we are resecting the bladder tumor cystoscopically with cystoscope. So we can remove this ulcer and we will send to the pathology. And sometimes we are injecting, like we are injecting Botox in the bladder, we are injecting a steroid inside the ulcer. My personal experience is very useful. The patients that they are crying because of pain and dysuria, and if I injected a steroid with the needle of Botox injection inside the ulcer, it was very useful. So, we want to talk about updates treatment. We had knowledge before for years, for all our textbook. They talked about bladder pain syndrome, but now we know that ICM bladder pain syndrome is a one disease, but one disease with another disease that affect all the bladder. Okay, I want to emphasize, I have time, Mr. Chairman? I have time?
Biraz bitirmemiz lazım.
Okay. Okay. Teşekkür ederim. Symptoms, if the patient has pain, pressure, or discomfort in the bladder, we should consider about IC and bladder pain syndrome. History is very important. You should know about the lifestyle, the another disease, the emotional score of patients, and if we reach to the IC, we will go to treatment. So I want to go very fast. So we should check history, previous illness like surgery, location of pain, and duration, familial history. The previous radiation is very important, autoimmune syndrome, and we should check about the pain in all positions, standing, sitting, and also vaginal examination is very important for rule outing HPV and blah, blah. You know better than me. And what is the treatment? We have conservative treatment, a special diet, behavior therapy, and oral therapy. What's the oral therapy? If you sit in your office in clinic and you have IC patients, you should give combination of amitriptyline, antidepressant, pentosone polysulfate. It's available all in Turkey. It's not available in Iran. The patients, they're buying from here, pentosan. Immunosuppressive, intravesical and intradetrusor therapies. We have DMSO, glycosaminoglycanate for instillation inside the bladder, BCG, Botox, and neuromodulation and surgery. I think it is useful for you. Amitriptyline, 25 to 75 milligram at bedtime. 63 patients, they have improvement. Other antidepressant like duloxetine is useful. Antihistamine is one of the best treatment for these kind of patients. And cimetidine, pentosan polysulfate, Elmiron, everybody knows about Elmiron, and immunosuppression medicine, cyclosporin, L-arginine, and also antibiotic. If we want to give antibiotic, doxycycline is one of the best. Intravesical therapies that we are doing an installation of some medicine inside the bladder, like every 2 weeks. They are coming every 2 weeks to our clinic. We are giving DMSO and many products like hyaluronic acid that is available in the market, and Botox injection. The Botox injection is, we are injecting only allergan, not Dysport, 200. We are diluting in 200 milli of normal saline, and also submucosal triamcinolone and steroid, 10 to 40 milligrams, very useful in Hunner ulcers. Intravesical Dysport&BotulinumA, we did some study in Kuwait. We had 81 patients in 8 years, and some men also, they are suffering. We did Botox injection. It was very successful, especially for 6 months. And so I think I should go to neuromodulation. If some patients that they are suffering from painful bladder syndrome, still after medical therapy, after Botox, one of the best way is doing TENS. Your physiotherapists in Turkey, they are very professional. Acupuncture, epidural blockade, and sacral nerve modulation. That I did for only for 5 patients that they didn't reply to another kind of medicine. It was very successful. We are doing sacral nerve modulation, and I will be happy. It will be my pleasure having you in 1st November. We will have hands-on training for sacral nerve modulation. It is very tricky surgery, but it is not difficult in your professional hands. And we are doing to S2, S3, and we are putting the needle for blocking the sacral nerve modulation. I'm doing for neurogenic bladder, also for painful bladder syndrome. Surgical therapy is hydrodistension. We are doing every week hydrodistension. The patient coming to our clinic, we are putting normal saline, and because of the gag layer of bladder, because of the one etiology, we are doing hydrodistension, and the bladder wall going to be a little bit like rupture, and then they feel better. And initial hydrodistension is very important. If we will see Hunner ulcer, we should resect the ulcer, or we should inject a steroid inside. And IC and bladder pain syndrome is not only one disease. We should do holistic approach. And multidisciplinary approach is very important for these kinds of mysterious patients. What is the holistic approach? Managing painful bladder with pelvic floor pain, because it is challenge, we need the multidisciplinary approach. We need multidisciplinary center with gynecologists, pain therapists, urologists, colorectal, sex therapists, of course gynecologists. Because I like to work multidisciplinary, and also emphasizing that our Congress is multidisciplinary in November. I think I gave all the information, but we have some algorithm and guidelines. I signed the consent that you can have my PowerPoints, you can have this very new guidelines, And you cannot imagine how much the patients with IC and bladder pain syndrome, they are suffering in their life, and as a doctor, we should help them. About sexual life of ICM patients, I did a research in 21 patients that they had IC, only 21, a small group, but they didn't have sex life. They were young, new married. They couldn't tolerate having sex life with their partner. With every sex, with every penetration, the symptoms of the patients was very severe. They want to go to divorce because they couldn't tolerate the sexual relationship. They didn't have sex life because of bladder pain syndrome. So we have some solution for them, like changing the position. In IC patients, the sex should be female superior, because if at the sex time they have pressure on the urethra, on the suprapubic, they will have really severe pain. So sex life of IC patients and bladder pain syndrome is very suffering subject for them. And also the bride suffering bride with IC and bladder pain syndrome always should be at toilet, even at the wedding party. And imagine how much is difficult the life and sex life for patients with IC. Thank you.